Bismillahirrahmanirrahim. Ignorance is the curse of God. Knowledge is the wing wherewith we fly to heaven. A quote by the William Shakespeare. Today the topic of presentation is Situation of Pakistan in Maternal and Newborn Care under the supervision of Professor Dr. Saira Afzal. The learning outlines of today's presentation are Pakistan demographic and health survey trends and figures related to the situation of Pakistan in antenatal care, care during delivery, postnatal care, fertility, family planning, child health and maternal and childhood mortality, and the National Vision 2016 to 2025 for coordinated priority actions to address challenges of reproductive, maternal, newborn, child, adolescent health and nutrition. By the end of this presentation, participants will be able to describe the situation of Pakistan in maternal and newborn health according to the Pakistan Demographic and Health Survey 2017 and 18 and 10 priority actions to combat challenges of reproductive, maternal, newborn, child, adolescent health and nutrition goals according to National Vision of 2016 to 2025. Pakistan is the sixth most populous country of the world. The population of Pakistan is 220 million. 64% of its population is living in the rural areas. There has been rapid population growth since it came into existence, and given current rate of population growth, Pakistan will be the fifth most populous country globally by 2050. Now the antenatal care. The trends in antenatal care coverage in 1990, antenatal care by skill provider are 26%, while in 2017, the antenatal care by skill provider is 86. While the antenatal care in the first trimester increases from 15 to 55 in from 1990 to 2017, while the 4 or more antenatal care visits increases from 14 to 51 from 1990 to 2017. While the components of antenatal care among the women who are pregnant, 89% have their blood pressure measured, 71% have their urine sample taken, and blood sample taken of 70 women. Patterns by background characteristics. Women who use antenatal care services from skill providers are those whose age are from 15 to 35 are more likely that are between the 85% to 88%, while their older counterparts whose age ranges from 35 to 49 are 78%. There is also differences in urban and rural women. Urban women who use antenatal care services are 94%, while the rural are 82%. There is also difference with respect to the wealth quintile. Those women whose wealth quintile is highest, they use 98% of antenatal care services, while the lowest wealth quintile uses 67%. Highest education category uses 99% of antenatal care services, while those who are illiterate uses 76% of antenatal care services. Antenatal care services usage is highest in Islamabad, being 94%, while it is lowest in Balochistan, that are 56%. 92% of women from Punjab are satisfied with the services provided during antenatal care as compared with only 56% of women from Balochistan. On the iron tablets, syrup and intestinal parasite drugs. 59% took iron tablets or syrups and only 2% took intestinal deworming drugs. There are substantial variations in iron supplementation by background characteristics. These women were more likely to have taken iron supplements during pregnancy than their counterparts. Those women who are pregnant with their first child are 67%, while 67% are those who are urban women, and 82% are those who are highly educated, and 79% are those who are wealthier, and 78% of Islamabad and 48% women from Fatah uses the iron tablets. The use of intestinal deworming drugs was highest among women in Balochistan, that are 5%, as compared to the other regions that are merely 2%. Counseling during the antenatal care. Counseling services provided during antenatal care visits with respect to breastfeeding and a balanced diet during pregnancy are 52% with respect to the early initiation of breastfeeding and 54% for exclusive breastfeeding for 6 months, while 7 in 10 women have received counseling regarding the balanced diet during pregnancy. Women were more likely to receive counseling if they were living in an urban area, in a higher education category, or in a higher wealth quintile as compared with their other counterparts. Now, the health facility births by region. These are health facility births are lowest in Balochistan and Quetta. In Balochistan, health facility births are 35%, while this is highest in Islamabad, that are 84%. There is also a change in trends in place of delivery from 1990 to 2017. The home deliveries in 1990 are 85%, while in 2017 these are reduced to 34%, while the health facility delivery increases from 13 to 66 from 1990 to 2017. And there is also a health facility births by education. If the women who are illiterate, their health facility births are 52%, while 93% of those women who are highly qualified, their health facility births are 93%. Assistance during delivery. About 60% of all the deliveries are conducted by the doctors, second being by the DIs and the traditional birth attendants, that are 24%, while 10% deliveries are conducted by nurses, midwives, LHVs or community midwives, while 5% are conducted by the relatives and others, and 1% are conducted by the lady health workers. The skilled assistance at delivery by mother's education also varies. Those women who are illiterate, the skilled assistance at delivery is 56%, while those who are highly educated, their skilled assistance at delivery is 94%. Deliveries by cesarean section. The proportion of births delivered by C-section has rapidly increased in the past 5 years, from 40% in 2012 to 22% in 2017. For 16% of total births, the decision to deliver by C-section was made before the onset of labor pains. Among women who gave birth by C-section, 74% stayed at a health facility for more than 3 days, as compared with only 3% women who had a vaginal birth. The majority of women, that are 69%, who had a vaginal birth in a health facility, were discharged fewer than 6 hours after the delivery. Protection against neonatal tetanus. Neonatal tetanus is the leading cause of death among neonates in developing countries. It is often because of the failure to observe hygienic procedures during delivery. From 2012 to 2017, the proportion of mothers whose birth was protected against neonatal tetanus increased by 5%, from 64 to 69%, while the proportion of women receiving 2 or more doses of tetanus toxoid increased by 4%, from 59 to 63% over the same time period. Now the postnatal care. First is the postnatal care for women. The proportion of women with postnatal checkup within 2 days after delivery has remained largely unchanged from 2012 to 2017. That are it increases with only 1%, from 61 to 62%, with most checkups occurring within the first 4 hours of delivery, that are 53%. However, 36% of women did not receive any postnatal checkup during the first 2 days after delivery. Postnatal care by place of delivery. Percentage of large births in the women whose postnatal care is conducted in the health facilities are 79%, while 90% have received postnatal care from elsewhere other than the health facilities, while the newborn postnatal care conducted in the health facilities are 81%, and other places are 20%. That type of care provider for the postnatal care, about 3/5, about 57% of women who gave birth in the 2 years before the survey received their first postnatal checkup from a doctor, nurse, midwife, lady health visitor, or community midwife. And there is also variation in the urban and rural areas. In urban areas, it is 73%, and in rural areas, it is 49%. Women who received postnatal care within 2 days of delivery with respect to wealth quintile, 87% of women with receive postnatal care whose wealth quintile is highest, while 44 women of lowest wealth quintile seek the postnatal care. Among regions, who only 32% of women residing in Quetta received appropriate time postnatal care compared with the 78% of women in Islamabad. Postnatal care for the newborn. Newborn received a postnatal checkup within the first 2 days after birth. Those who received are 64%, and those who did not receive are 35%, and those who received the postnatal care within the first hour of life are 41%. Early postnatal care decreases as birth order increases. Postnatal checkup during the first 2 days after birth for those babies who are first in order of birth are 71%, and for those babies whose birth order is 6 or higher is 51%. Babies born to women with respect to education receive postnatal care within the first 2 days after delivery. Those who are educated, their postnatal care for the newborn is 86%, while those who are illiterate are 50%. Babies born to women with respect to wealth quintile receive postnatal care within 2 days of birth than babies born to women in the highest quintile, that is 88%. Lowest wealth quintile is 46%. Among regions, only 34% of newborns residing in Balochistan receive postnatal care during the first 2 days after birth, as compared to the 77% of newborns in Islamabad. The type of provider in postnatal care of the newborn: 59% of newborns receive their first postnatal checkup from doctor, nurse, midwife, lady health visitor, or the community midwife. Newborn care practices during the first 2 days after birth. 64% of the newborns have umbilical cord examined, while 46% have their temperature measured, and 45% have their got breastfeeding counseling, while 27% have counseling on newborn danger signs, and 26% observed while breastfeeding, and 90% of the newborns are weighted. Newborns were put immediately after birth on bare skin of the mother's chest to 11%, and nearly 1 in 10 newborns bare skin was touching their mother's bare skin. Their number is 9%. Now the child health. Birth weight. Uh, the low birth weight babies born that whose weight is less than 2.5 kg is 22%. A finding that policymakers and program manager must take it seriously because it is a good indicator of a child health and nutrition. A majority of 81% of infants born alive in the 5 years before the survey were perceived by their mothers to be of average or large weight at birth. Low birth babies are in mothers whose age is under 20 or 34%, and mothers whose age ranges from 20 to 34 or 21%, and those whose birth order of 6 or higher is 21%, 25%, and while those whose birth order of 2 to 5 are 21%. Mothers who smoke cigarette, their babies, uh, low birth weight babies are 28%, while mothers who do not smoke cigarette are 22%. 33% of low birth weight babies are belong to the lowest wealth quintile, while 19% belongs to the highest quintile. Punjab has the highest percentage of low birth weight babies, that are 24%, and Sindh has 23%. Now the immunization status. The trends in immunization coverage also increases from 1990 to 2017 from 35% to 66%, while the no vaccine, those children who did not receive any vaccine, decreases from 28 to 4 from 1990 to 2017. The basic vaccine coverage for the BCG is uh, 88%, while for the pentavalent it is, for penta 1 it is 86%, for penta 2 it is 83%, and for penta 3 it is 75%, and for polio 1, 2 and 3 it is 95, 90 and 86% respectively, and for measles it is 73%. Vaccination coverage by region. The vaccination coverage by region, it is lowest in Balochistan, followed by Fata, and it is highest in Punjab, that is 80%. Now the childhood illness. In the 2 weeks before the survey, 14% of children under 5 were ill with symptoms of acute respiratory tract infections such as chest-related short, rapid breathing, or difficult breathing. Among these children, treatment or advice was sourced for 84%. More than one third of children under 5, about 38%, had fever in the 2 weeks before the survey. Among these children, treatment or advice was sought for 81%. 1 in 5 children under 5 had diarrhea in the 2 weeks before the survey. Diarrhea was most common among children whose age is between 6 to 11 months of age, that contribute to 31%, and 71% of children under 5 with diarrhea had treatment or the advice has been sought for them. Children with diarrhea should drink more fluid, particularly through ORS, which includes oral rehydration salts, recommended home fluids, and increased fluids. Additionally, children under 5 with diarrhea should receive zinc. While 43% of children under 5 with diarrhea received oral rehydration therapy, 14% received no treatment. Only 8% of children under 5 with diarrhea received ORS and zinc. Now the newborn death. Newborn deaths are still a major contributor to under 5 mortality, with around half of under 5 deaths occurring in the first month of life, and that the number is 202,000 per year. The major contributor for the newborn death is sepsis, that is 34%, followed by the prematurity, that is 27%, and for asphyxia it is 24%, and for congenital anomalies it is 10%. The leading cause of death during the postnatal period are diarrhea, and that is 27%, and pneumonia, that is 26%. Death from both pneumonia and diarrhea are closely associated with overlapping risk factors such as those related to the poverty, undernutrition, poor hygiene, sanitation, and deprived home environments. Feeding practices and supplementation. The breastfeeding status for children, those about 48% of children are exclusively breastfeed, while 13% of children receive breast milk plus complementary foods, while 33% of children are breastfed and also received other liquids, while there are only 7% of the children who did not receive uh, breastfeeding. Breastfeeding and the introduction of complementary foods. Breastfeeding is very common in Pakistan, with 94% of children that are ever breastfed. 1 in 5 children were breastfed within the first half of life. More than three quarters, about 76% of children who were ever breastfed received a prelactal feed, though this is not recommended. WHO recommends that children receive nothing but breast milk, that is exclusive breastfeeding for the 6 months of life. Exclusive breastfeeding for children under 6 months has increased from 38% in 2012 to 48% in 2017, while exclusive breastfeeding among children of ages 4 to 5 months has increased from 24% to 35% over a 5-year period. Similarly, exclusive breastfeeding among children of age 2 to 3 months has also improved from 36% to 52% in the same time period. Children ages from 0 to 35 months have received breastfeeding for a median of 19.4 months and are exclusively breastfed for 1.6 months. Overall, 48% of children of ages 0 to 23 months are bottle fed. Complementary foods should be introduced when a child is 6 months old to reduce the risk of malnutrition. In Pakistan, 54% of children of ages 6 to 8 months are breastfed and receive complementary foods. Vitamin A and iron supplementations in children. Macronutrients are essential vitamins and minerals required for good health. Vitamin A, which prevents blindness and infection, is particularly important for children. In the 24 hours before the survey, 48% of children of ages 6 to 23 months of age eat food rich in vitamin A. Three quarters of children of ages 6 to 59 months receive vitamin A supplement in the 6 months prior to the survey. Iron is essential for cognitive development in children, and low iron intake can contribute to the anemia. Nearly 40% of children eat iron-rich foods the day before the survey, while only 7% received an iron supplement in the week before the survey. Pregnant women should take iron tablets for at least 90 days during pregnancy to prevent anemia and other complications. Only 29% of women took iron tablets for at least 90 days during their last pregnancy. Now, the nutritional status. Childhood stunting by region. The childhood stunting is lowest in Punjab and it is highest in FATA region, that is 42%, while in Punjab it is 30%. Now the malnutrition. Nearly 2 in 5, about 38% of children under 5 in Pakistan are stunted or too short for their age. Children whose mothers have no education, about 48%, and those from the poorest household, 57% are most likely to be stunted. Only 17% of children are wasted. In addition, 23% of children are underweight. Nearly half, about 45% of children under 5 were stunted in 2012 as compared to 38% in 2017. Childhood wasting declined slightly from 11 to 7% in the same time period, while the prevalence of underweight children declined from 30 to 23%. Women's nutrition status. In 2017, according to the Pakistan Demographic and Health Survey, also took weight and height measurements of ever married women of ages 15 to 49 years. Over 9% of women are thin, whose body mass index is lower than 18.5. Comparatively, 52% women are overweight or obese, whose BMI is greater than 25. Women in the wealthiest household are more than 3 times as likely to be overweight or obese as women from the poorest households, and that are 73% versus 23%. Overweight or obesity among women has increased from 40% in uh, 2012 to 52% in 2017. This is the graph that is all already been discussed in the know the fertility and its determinants. The trends in total fertility rate has declined from 4.9 to 3.6 from the time period of 1990 to 2017. About 1.3% has there is a decline of fertility, and the total fertility rate by household wealth. Uh, the fertility rate goes on decreasing as the wealth quantile increases. And those who are poor families, their fertility rate is 4.9, while those whose wealth quantile is highest, their fertility rate is 2.8. Fertility is the number of child per woman. Total fertility by region. Uh, Fertility rate is lowest in Punjab within the Pakistan, that is 3.4, while it is highest in FATA, that is 4.8. Teenage fertility. In Pakistan, 8% of adolescent women aged 15 to 49 years are already mothers are pregnant with their first child. Teenage childbearing has remained the unchanged since 2012 to 13. 5% of adolescent women in the wealthiest households have begun childbearing compared to 10% of adolescent women in the two lowest wealth quintiles. Consanguinity. Pakistan has the highest rate of marriage between cousins. Half of all marriages occur between first cousins. 29% of women marry first cousin on their father sides, while 20% on the mother side. Total fertility rate by education. The fertility rate of educated women are 2.6, while those who are illiterate is 4.2. Age at first marriage and birth. Median age at first marriage of women are 20.4 years, while those of men are 25.9 years, while the median age at the first birth of women is 22.8 years. Women with no education marry more than 6 years earlier than women with higher education, 18.7 years versus 24.9 years. Thin Pakistani women are married by age 18. Women have their first birth more than 2 years after marriage. 13% of women give birth by the age of 18 years. On the family planning. The family planning usage by the percent of women who are married from the ages of 15 to 49 years. 34% of women are using any method of contraception, while 25% are using the modern methods of contraception. 9% of using male condoms, while the 9% of female are have got sterilization, while 3% are using the injectables, while the 9% are using any traditional methods, while 8% are using the withdrawal method. The modern method used by region. The contraception usage is lowest in Balochistan, that is 14%, and it is highest in the Gilgit-Baltistan region, that is 30%. Trends in family planning usage. The family planning trend has also changed from 1990 to 2017. Uh, uh, by any method of contraception, it increased from 12 to 34%. Modern usage by household wealth. And the family planning methods has increases from as the wealth quantile increases. Demand for family planning. About 2 in 5 married women, 90% want to delay childbearing, delay first baby or space and another birth for at least 2 years. Additionally, one third of married women do not want any more children. Women who want to delay or stop childbearing are said to have a demand for family planning. The total demand for family planning among married women in Pakistan is 52%. The total demand for family planning includes both met and unmet need. Met need is contraceptive prevalence rate. In Pakistan, 34% of married women use any family planning method. Informed choice. Family planning clients should be informed about the side effects of method used, what to do if they experience side effects, and told about other available family planning methods. More than one third, about 35% of current users of modern contraceptive methods were informed of possible side effects or problems of their method. 24% were informed about what to do if they experience side effects, and 44% were informed of other available family planning methods. Overall, 90% of women were informed of all three. Unmet need for family planning. Unmet need for family planning is defined as the proportion of married women who want to delay or stop childbearing but are not using any family planning method. In Pakistan, 70% of married women have an unmet need for family planning. 10% want to delay childbearing, while 8% want to stop childbearing. Unmet need has slightly declined from 20% in 2012. Unmet need for family planning decreased with wealth from 23% among married women in the poorest household to 14% among married women in the wealthiest households. HIV knowledge. Knowledge of prevention of mother to child transmission. 16% of ever married women and one quarter of men know that HIV can be transmitted during pregnancy, delivery, and by breastfeeding. Less than 10% of women and 23% of men know that HIV transmission can be reduced by the mother taking special medication. Now the mortality. Trends in childhood mortality. Under 5 mortality, infant mortality, and neonatal mortality goes on decreasing from 1990 to 2017. Under 5 mortality by previous birth interval, uh, the under 5 mortality is 122, 122 for those whose birth interval is less than 2 years, and it is 51 for those whose birth interval is of 2 years, and it is 41 for those whose birth interval is 3 years, and it is 44 for those whose birth interval is four or more than 4 years. At these mortality levels, 1 in every 14 Pakistani children does not survive to their first birthday. Spacing birth at least 36 months apart reduces the risk of infant death. The median birth interval in Pakistan is 28.2 months. Overall, 30% of children are born less than 2 years after their siblings. Now, under 5 mortality by region. It is low. It is lowest in FATA, that is 33%, and it is highest in the Balochistan, that is 78%. The under 5 mortality by mother's education. Under 5 mortality decreases as the mother's education goes on increasing, as shown in the graph that those women who are illiterate under 5 mortality is 95 per thousand live births, and for those whose education is higher, their under 5 mortality is barely the 38 per thousand live births. This picture shows that if the woman goes on increasing in women education, then there is the decrease in infant mortality. Perinatal mortality. The 2017 and 18 Pakistan Demographic and Health Survey yields a perinatal mortality rate of 57 deaths per thousand pregnancies of 7 or more months duration. Perinatal mortality is twice as high for women who become pregnant less than 15 months after a previous pregnancy. that is 78 per thousand pregnancies. As for women who became pregnant 39 months or more after previous pregnancy, that is 29 per thousand pregnancies. The perinatal mortality rate is higher in rural areas, that are 60 per thousand pregnancies, than in urban areas, that are 50 per thousand pregnancy. Perinatal mortality ranges from high of 62 per thousand pregnancies in Punjab to a low 23 per thousand pregnancies in FATA. Perinatal mortality by mother's age at birth. There are 84 deaths per thousand pregnancies for those whose birth interval is less than 20 years, and it is 55 deaths per thousand pregnancies whose birth interval is less ranges from 40 to 49 months. Now the maternal mortality. There are also wide variations between provinces in maternal mortality. It is being lowest in Punjab, that is 227, and it is highest in Balochistan, that are 785 deaths per 100,000 live births. One of the main reasons for this high maternal mortality rate is very low utilization of family planning services. Pakistan maternal mortality ratio has declined from 521 in 1990 to 332. The range is from 250 to 432 in 2012, still far behind the proposed target of 130 by 1215. An estimated 14,000 Pakistani women die every year of pregnancy-related causes. Mortality rate by background characteristics. The under 5 mortality rate differs by mother education, wealth, and region for the 10-year period before the survey. Children whose mothers have no education are more likely to die young, 91 deaths per thousand live births, than children whose mothers have higher education. Their mortality is 38 deaths per thousand live births. Under 5 mortality is nearly 2 times higher among children in poorest household, that are 100 deaths per thousand live births, compared to children in wealthiest household, that is 56 deaths per thousand live births. Regionally, under 5 mortality ranges from 33 deaths per thousand live births in FATA to 85 deaths per thousand live births in Punjab. Now the national vision for the years of 2016 to 2025 for coordinated priority actions to address the challenges of reproductive, maternal, newborn, child, adolescent health and nutrition. The Prime Minister of Pakistan at that time, Mir Mohammad Nawaz Sharif, during a meeting in February 2015 with international and national leaders in public health, expressed his concern on slow progress in reproductive, maternal, newborn, child, and adolescent health and nutrition-related aspects in Pakistan over the last decades. He further added that international practices should be replicated in Pakistan to achieve the better results. Subsequently, a consultative process was initiated between all stakeholders to identify priority areas and identify clear strategic directions for RMNCAH and nutrition for the next 10 years with tangible results, outcomes, and a mechanism for oversight in order to ensure priority and visibility for the cause of mothers and children of the country. The poster for this national vision is to strengthen and invest in care during pregnancy, labor, birth, first day, week, year of life along the continuum of care approach, and to improve the quality of maternal, newborn, child health, and adolescent care, and to reach every mother, newborn, and child to reduce inequities and harness the power of parents, families, and communities, and to count every matter, newborn child and adolescent through measurement program and tracking and accountability. Accelerating progress on Millennium Development Goals of 4 and 5 for building new momentum beyond 2015. Government of Pakistan remains committed to support the efforts being undertaken to accelerate the improvement in newborn, child and maternal survival, especially focusing on reducing morbidity and mortality linked to common preventable causes. This goal can be achieved through following 10 priority actions that are briefly discussed one by one. The number one action is to improving the access and quality of reproductive, maternal, newborn, child, and adolescent health, primary care, community-based services, ensuring continuum of care, including newborn care in rural districts and urban slums. Primary care services in rural areas of Pakistan are critically dependent upon the Lady Health Workers Program and a relatively recent initiative to produce more community midwives. The most recent formal evaluation of the LHW program and a number of informal reports post-devolution have identified several areas of weakness and opportunities for further enhancement of their knowledge and skills, especially around standard best practice for maternal, newborn, and child survival. Number second action that has to be taken is improve quality of care in district facilities, including rural health centers and district hospitals. Facility-based services should be available for mothers, newborn children, and adolescents across the continuum of the care, from preconception through childbirth and postpartum period through childhood to adolescence and over the various tiers of service provision. Administrative and legal steps to develop linkages between medical colleges and universities with district health system can act as a game changer. Human resources, especially female medical officers, lady health visitors at rural health facilities need to be staffed with competent cadres capable of delivering quality maternal and newborn care at first contact with formal health services and regular on-job training. Expanding service access and uh, uh, 24/7 and supporting facility infrastructure, developing referral pathways and linkages. Overcoming financial barriers to care seeking and uptake of interventions. Targeted conditional cash transfer provide direct cash payments to poor households contingent to on certain behaviors that are routine vaccination, nutrition supplements, care seeking for high impact, high mortality conditions that are diarrhea disease, pneumonia, antenatal care, visit for pregnant women, family planning, delivery and postpartum care, health insurance schemes for identify poorest and